All right, it is 8 a.m. We will go ahead and get started. Welcome to Coplow Rounds. My name is Kelsey Brown. I'm one of the staff pathologists here at Coplow, and I will be going through our first two cases. Also, Happy New Year. Yes, Happy New Year. All right, so my first case, we just have a clinical photo, which is lovely. This is the globe from a 7-year-old male castrated French bulldog. We can kind of see the issue in this image here. The history that was provided for us is that this dog developed a corneal mass in the left eye. It seems like this has been an ongoing problem for about 10 months. And this eye also does have corneal pigmentation, which if we kind of look past our obvious corneal mass here, we can see some pigmentation of the cornea. It's pretty extensive, with maybe a little normal cornea at the periphery here. This eye, they said, did not have glaucoma, and this dog was otherwise healthy. And I don't have a gross image from this globe, but we can just corroborate grossly that there was this tan multilobulated mass kind of sitting maybe axial to medial paraxial on the cornea. Grossly, we thought the eye otherwise looked relatively normal. So we will go ahead and move to the histo. So I have two slides from this case. First one is not going to have the mass on it. So we first hemisected this globe, and then we trimmed in the mass for a separate slide, just to make sure we captured all the salient features of the mass and didn't lose it while this globe is getting sectioned. So really, this section just serves to highlight the corneal disease, which is relatively chronic. So even from low power view, so here's our cornea. We have our corneal epithelium on the right, heading posteriorly to Descemet's membrane on the left here. And we can already see just that pretty extensive pigmentation. I'll go a few closer even. Maybe right here. All right. So from this view, we can see melanin pigment within the corneal epithelium, which is not normal. There should be pigment in the epithelium. This epithelium is also somewhat hyperplastic, maybe mildly so. Usually corneal epithelium should be just a couple cells thick. In this case, maybe we have up to 7 cells. And in some areas we can see it is doing very light keratinization. So there's this little kind of keratin flake coming off, which is also not normal for the corneal epithelium. Moving back to looking at the more superficial stroma, there is vascularization. You can see these rather large vessels, as well as some inflammation, so some lymphocytes and plasma cells, as well as some melanin-laden macrophages. So this here is pigmentary incontinence. So essentially, this melanin pigment gets released from the epithelium into the stroma, and these macrophages gobble it up and then kind of sit here. And scrolling around, there's also areas where it does look like maybe there is some also mild fibroplasia of the corneal stroma. So going more posterior, this is maybe more mid-level stroma. It kind of has the loose, normal lamellar arrangement of the collagen. As we get more superficial, it kind of just looks more compact and dense. So probably some degree of fibrosis, which would not be surprising. All of these changes in this cornea are quite chronic. And all of these together, so vascularization and fibrosis, epithelial pigmentation, this would all contribute to corneal opacity. So grossly, we really could not see through that cornea, and we have good reason why. And then just quickly fanning over the rest of this globe, there really isn't anything else too exciting here to show. So we have a nice open iridocorneal angle. This side didn't have glaucoma, so that tracks. We don't often get to see a nice open angle, so sometimes we do appreciate it in the pathology world. There are also some little kind of thick-walled iridociliary cysts, these guys floating in the posterior chamber. In this case, probably just an incidental finding. We do see these in globes that don't have glaucoma or other conditions, so it's possible, yeah, it's just incidental and of unclear significance. But we have a nice normal lens, and then going back, also our retina and optic nerve head look great, which again is kind of a treat for us to see. We don't normally see that many normal retinas and optic nerve heads. All right, now I will switch over to our other section that actually has the corneal mass. So this is what we call, technical term, a corneal banana, where we just take the other half and we cut in the cornea and kind of don't include much of the posterior segment. And you can see our mass right here. So kind of, yeah, axial to paraxial cornea. Our mass comprises a epithelial neoplasm. closer. We're kind of at the junction of normal and abnormal. So here is our kind of non-neoplastic, at least, corneal epithelium, definitely still not normal. And then it progresses to this expansion of the epithelium. Closer. So you can see in a lot of these areas, there is severe thickening of the epithelium. These cells have lost their polarity. So if we go over to kind of our more normal-ish epithelium, we can still see normal polarity of the cells. So there's this compact basilar layer. And as it gets more superficial, it turns into this more terminally differentiated layer, which has larger cells. They're starting to keratinize as well. If we go over to this region where we have our mass, there's just jumbling of those layers. So maybe there's kind of this remnant of a basilar layer, but it's jumbled in with these more kind of terminally differentiated and keratinizing cells. And as we move around, we can also see that there's pretty significant atypia. So maybe there's a binucleated cell here. These have large nuclei with gigantic nucleoli, sometimes 2 nucleoli. That's more. And yeah, just a good amount of anisocytosis and anisokaryosis. So variation in nuclear size and cell size. And in some areas, here we go, we have these kind of bizarre mitotic figures. Oftentimes they're also above the basilar layer, which is not normal. Typically, if we see mitoses within our stratified squamous epithelium, it should be within just the basilar layer. So all of these features allow us to call this a epithelial neoplasm or a squamous cell carcinoma. In this case, if we look along kind of the base of the neoplasm, we don't really see any areas of stromal invasion. So this would be a squamous cell carcinoma in situ, which potentially is less metastatic potential compared to just a conventional or invasive squamous cell carcinoma. And we can also see as we look around kind of similar things that we saw in the first slide. So that melanin or pigmentary incontinence, stromal fibroplasia, vascularization, all of that. And as we look at the margins, it looks like it was completely excised. So we return to normal non-neoplastic epithelium on either side. Great. So I will move over to next views. So yeah, our major things was the mass, which was a corneal squamous cell carcinoma in situ. And then we also have this background of chronic keratitis, which there is a somewhat older publication now of a case series of corneal squamous cell carcinoma in dogs that have this background of chronic keratitis. So in this case series, brachycephalic dogs, such as the French bulldog in our case, were overrepresented. And all these dogs had just this non-specific chronic keratitis, and some of them are also on topical immunosuppressive medication, which is thought to maybe be a risk factor for development of squamous cell carcinoma in the cornea, including squamous cell carcinoma in situ. But hopefully this will have a good prognosis since it's been completely excised. All right, and that is what I have for that one. If there are no questions, then I can move on to the next case. Okay, I get the thumbs up. All right, so next case is from a cat. This is the globe from a 13-year-old female spayed American curl. We got a extensive history here. They said that this eye had glaucoma and severe ophthalmos. They described an expansile pigmented tumor on the ventral aspect of the globe, causing deviation of the globe dorsally. The globe couldn't be retropulsed due to its size. There was also moderate corneal edema with chorotic precipitates and a white-gray discolored anterior chamber, maybe due to flare or fibrin. Sounds like it was quite hard to see within this globe. This has been an ongoing problem for about 4 weeks. And under our general medical conditions, part of the history form, they said the cat had been healthy until recently. A CBC in chem was performed. It had no significant findings. And I will withhold the rest of the information under general medical conditions for the big reveal at the end. So here is our gross hemisection. Our optic nerve head is going to be at the bottom somewhere. It's not easy to see here, but it should be there. We have our cornea up top. And we can already say that this is a very ophthalmic globe for a cat. This is a quite large globe. And grossly, we had described that the iris leaflets were thick and kind of pale tan to yellow. We also noted that there was this kind of tan material overlying the iris, as well as the rest of the uveal tract. Even looking at a ciliary body, we can also see kind of these pale tan masses, perhaps. And then there's this kind of cloudy gel within all of the chambers. And then on the right side here, so this is our ventral aspect of the globe, we can see the sclera does become quite thin in areas, which we'll look at histologically as well. All right, so. And this is one of our extra large slides. Let's see if I can do a subgross for this. Maybe. And also didn't really fit in the cassette well, so it's kind of awkwardly on the slide. Yeah. Okay. So we have our cornea up top here, kind of moving down is where our optic nerve head will be. We can already see that there's a lot of material within the ocular chambers. A little hard to make out what it is. It kind of just looks like this pink, purple, hazy material. As we kind of move around, so here's our ventral aspect of the globe. We can see that the sclera is quite thinned. As we move around, here's one of our iris leaflets. It looks a little more pale, so maybe there's some edema in the stroma. And there's also this kind of suspicious purple layer on top of it. As we move back, a little bit hard to see other parts of the uveal tract. We can go closer to see that. It does look like there's kind of this thinning and outpouching of the sclera on this side. So perhaps we have a staphyloma. There's a mysterious blue dot that we can ignore for now. And as we move around, there's other areas where maybe the ciliary body is a little bit more distinct on this side, and there is just still kind of this distortion. Is a little bit hard to make out the fine details of its architecture, but there is increased purple, which usually means that there's some sort of cellular infiltrate. Then we have our lens in the middle, and there is a cataract. I can also show that at higher power. All right. Ooh, it's huge. All right, so the globe has now been flipped 90 degrees. So the cornea is on the right, posterior segment is going to be on the left. And there really isn't too much to say about this cornea. There is some vascularization, but that's not the most exciting part of this globe. A little bit more. We can see maybe there's some cells floating in the chamber here. A lot of this does seem to be just kind of eosinophilic homogeneous material, so kind of proteinaceous exudate. As we move over to our iris, we can see there is some sort of cellular layer kind of surrounding the iris leaflet on the anterior and posterior surface, as well as maybe cells within the stroma. And it kind of continues all the way back throughout pretty much the entire uveal tract. So we'll go ahead and just land on those without further ado. So there should normally be this layer of cells on the anterior surface of the iris. And this is a homogeneous population of cells. They're displaying pretty significant atypia. So this is a neoplastic population. And when it's lining uveal structures, it's kind of forming this stratified appearance or pseudostratified appearance. And then when it gets into the stroma, there's this invasive population. It's making more of kind of these centrally cavitated lobules. So just going even one closer. So these cells are polygonal. Sometimes we can kind of see pretty prominent cell borders between them. So this morphology is most consistent with an epithelial population. Nuclei round to oval, we have finely stippled chromatin, and one, sometimes two, pretty prominent magenta nucleoli. Zoom around here to show other areas. So in our ciliary body, you can see more of this stromal infiltration, kind of these lobules with cavitations. Sometimes they make kind of these more like tubular arrangements. Going a little bit more to my dot. I can find, And sometimes these cells do have these pretty prominent apical cilia, which kind of helps say exactly where these cells could have come from or provide more specific differentials. So this is an epithelial neoplasm, so a carcinoma. In this case, we have this cell carpeting of the uveal surfaces, as well as pretty extensive infiltration of the uveal tract. So this pattern or distribution of these cells is most consistent with a carcinoma that's metastasized to the eye from another location within the body. In cats, probably the most common place for that primary tumor is going to be the pulmonary tract. And in this case, we do have apical cilia on these neoplastic cells. which we do tend to see with our pulmonary carcinomas in cats. So in this case, the pulmonary tract would be a fine place to be searching for a primary tumor. And I'll just kind of go around a little bit more to show the rest of this eye. So here's our optic nerve head. It's a little bit distorted, possibly just due to compression, but despite that, we still can see this kind of atypical population of cells within the optic nerve head. So we do have infiltration by the neoplasm. It does extend to the optic nerve head margin, unfortunately. And moving around, you can see the rest of our uveal tract. As we move ventrally, this is where we run into that kind of staphyloma or outpouching of the sclera. It looks like in this location, the sclera is super thin, and it looks like there's more neoplastic cells that have infiltrated the sclera as well, probably causing that distortion. In this particular area too, so here's our iris moving to ciliary body. It's kind of become detached from the sclera and kind of undermined by these neoplastic cells and this debris here. So a little bit hard to make out the exact architecture of what's going on here. And at some point we kind of pick up our cornea again. There is this is an artifactual discontinuity in our limbus/peripheral cornea. There's a very sharp discontinuity, which usually we don't see with, say, like a scleral rupture. So probably just didn't get sectioned in completely. And then myself here, there we go. And then moving over, just quickly showing our lens. We do have a cataract, so we have liquefaction of our cortical lens fibers and formation of these Morgagnian globules, which are hallmarks of a cataract. And then lastly, just within our chambers, in addition to this kind of proteinaceous material, there's kind of neutrophils that are free floating around in here. There is quite a bit of necrosis associated with this neoplasm, so a neutrophilic infiltrate is not out of the ordinary in response to that. All right, so we will move over to the PowerPoint. Show our diagnoses. So yeah, the appearance of this neoplasm, its cell patterning and distribution, most consistent with metastatic carcinoma, and we suggest most likely coming from the pulmonary tract. And in the history for this patient under general medical conditions, they did do patient staging, and chest radiographs revealed a 3-centimeter pulmonary mass. And they actually did perform an FNA on this mass, and the cytology revealed that it was probably a carcinoma. So I think by Occam's razor, most likely this carcinoma from the pulmonary tract has metastasized to the eye. So that kind of wraps it up neatly. And unfortunately, there were dirty optic nerve margins as well as our episcleral margins at that area where the staphyloma was. So it's possible there could be local recurrence as well in this case. All right, with that, I can hand over the scope to our next presenter. You can stop the questions. Oh, let's show your slides. Sorry. Thank you.
All right, I'm Megan, and I've got the next 2 cases. So this first case is a 1-year, 5-month-old, so very young, cat, domestic short hair, neuter male. This cat has a history of non-responsive glaucoma of the left eye. And interestingly, they did a cyclocryocoagulation or cyclocryoablation on this case. So ablative procedures are usually designed to try and damage or get rid of the ciliary body epithelium, which is the epithelium that produces aqueous humor. So mostly with glaucoma, the problem is a clogged drain essentially, and with ablative procedures like that, you're trying to turn the water down basically, try and help with pressure. So there's a number of ways to do that, including with lasers, but using a cryoprobe is one of them. And it's a kind of neat feature on the gross. You can actually see kind of right where the level of the ciliary body would typically be, just a little bit posterior to the limbus. There are these little slight depressions that are pretty like regularly circular, which is kind of cute. And these are most likely spots where the cryoprobe touched the globe. Actually, inside the globe, this is the other half of the globe because we didn't initially have a picture of this case. It didn't really look too grossly impressive initially. But one thing that we can see is that the limbus is actually way up here, and then the iris is way down here. So usually the iris would be a little bit closer up by the limbus, and this huge posterior displacement is what we refer to as a retrocorneal angle recession. And there are other possible causes of that, but it's one thing to see grossly. Otherwise, the iris doesn't really look that impressive. Maybe it's a little bit thickened, maybe. Doesn't really jump out at you though. And then we'll take a look at histology. Okay. I know there's probably a better way to do that, but I haven't figured it out. So here's our little kitty globe. Again, set up nice. You can see the, it's a little bit out of focus because it's some gross situation, but you can see that the limbus is maybe roughly up here based on the difference in kind of the staining characteristics of cornea relative to sclera. And then again, the iris being way, way back here, so that a retrocorneal angle recession. The iris is looking a little bit thick, maybe, and a little bit maybe purpler than usual. And then what might also catch your eye is all this stuff kind of glommed onto the lens, which we'll take a closer look at as well. All right, so the globe has been rotated 90 degrees clockwise here. Our cornea is way up here. We're going to focus in on the uvea. So we zoom in on this iris. It's pretty busy. So there are a lot of cells in the iris stroma here. We go even more closer. And these cells are actually pretty abnormal. So we have these sort of spindle to stellate cells. They have nuclei with a coarsely clumped chromatin and a single distinct nucleolus. These are a lot more active and actively dividing than your typical resident stromal cells. Similar cells are also carpeting the uveal surfaces. So you can see this carpet of abnormal cells on the anterior iris here. You can see them carpeting the ciliary body surface through here and invading the ciliary body stroma. Here they are. And then all of that stuff that was glomped on to the lens and kind of forming these weird membranes in the vitreous are similar cells. They are sort of spindle to stellate cells, kind of active. And I think if you go even as far back as the retina, these same cells are carpeting the epiretinal surface. So they're getting pretty extensively carpety all the way around the globe. And what's kind of interesting about these cells is even way back here, away from the uvea has resident melanin. And if it gets necrotic, some of that melanin can go floating and things like that. But even way back here, where there should be less melanin, there's occasionally melanin hither and thither. And sometimes maybe I could convince you it'd be neoplastic cells, which of course, being in the hot seat, I may not necessarily find. There we go. That's probably a decent area. This one looks to me like it's got melanin in the cell itself. So ultimately, this is a neoplastic melanocytic population. So we've got melanoma. And the pattern in this cat eye of carpeting like all of the surfaces, carpeting behavior like that tends to be a feature of metastatic disease, metastatic neoplasia to the eye from another site. That said, there are certain types of primary ocular neoplasms, which feline diffuse iris melanoma can be one of them, that can tend to kind of go climbing along surfaces too. So usually with feline diffuse iris melanoma, we don't see this extensive of a carpet, but I've seen it climbing along ligaments and things like that on occasion, so it could happen, theoretically. So those are essentially the two top differentials for this case, either a metastatic melanoma from some other site, or a feline diffuse iris melanoma that just has somewhat of an atypical presentation. And then the other weird thing about this case is that, going back to signalment, this patient is 1 year, 5 months old, so a pretty darn young patient. Let's see, in a couple months duration at that. So, you know, somewhere around 1-ish maybe when this was starting. So this is an unusually young age for this type of cancer. So, and not sure what the significance, if any, of that is. Just kind of an interesting or unique feature of this. Usually feline diffuse iris melanoma is a disease of somewhat older cats, for example. And then, just as a little bonus for this case, we look up here at the level of where the ciliary body used to be, at least before the angle recession, which was probably a consequence of distortion of the globe from neoplasia and ophthalmia. But we've got this little site here where the sclera is replaced by sort of new collagen with a different kind of character of the collagen fibers, lots of fibroblasts interdigitating, and some areas where the collagen is maybe a little bit devitalized or degenerate. So this is just what those cryoprobe sites look like. Just kind of cute. So that's this case. We will pull up the diagnoses. There you go. At least two of the key diagnoses. C comment, as you can see. An unusual case, this case, very unusual. Okay. There aren't any questions, we'll do the next one. This one looks like an eye unto itself, but it isn't. A little bit. I have a few holes to it. So this is a 5-year-old spayed female mixed breed dog. They describe the right eye as ophthalmic and non-visual. There was a lower eyelid margin mass, which we're going to not talk much more about. And there was a subcutaneous pigmented soft mass a few millimeters from the lower eyelid margin. So sort of a periocular subcutaneous mass. There's anterior uveitis with aqueous flare and iritis, they say, and a posterior lens subluxation and optic nerve degeneration. So a glaucomatous and ophthalmic right eye, and then a little bit below that eye, periocular, a little subcu mass. And believe it or not, even as an eye nerd, I'm going to focus more on the mass than the eye itself, but we will take a quick look at the eye. So here is a slice through that subcutaneous mass. We've got our haired skin at the top of the image. Here it is. We've got our dermis, and kind of sitting in our subcutis, we've got this weird little mass, which has this sort of orange capsule almost, and then all of this weird pasty kind of orange yellow goo. And then you might be wondering what this hole is. And so what I can tell you is that while this case was being grossed, the gross examiner cut into this little subcutaneous mass and hit something very hard that the blade would not pass through. This structure was spherical. I can actually read the actual notes. Let's see. Very hard, exclamation point. It was about 4 millimeter diameter. And so yeah, this would be kind of gray and sort of almost a perfect sphere. And so ultimately the gross examiner took a magnet to that thing, and it was magnetic. So long story short, what we found in the middle of this little mass was a BB pellet, or at least something similar, metallic foreign body, if we wanted to be safe about it. So that's really cute. Well, it's cute depending on your perspective, I guess. And kind of interesting is we had like 3 of these cases, or at least 2, like kind of close together, interestingly enough, all from different locations. But like just before this, for example, we had a case in a cat, and also used the magnet to great effect. But so let's take a look at for histo, which is just kind of neat. Here's the equivalent of our slice that we just saw on our gross. It's a little bit flipped from what we just saw, but here's that space where the metallic foreign body was sitting, and then it's sitting in this weird encapsulated sort of gooey focus. Back closer. There's some kind of neat features. So it's sort of encapsulated by fibrosis, and then just inside that, we've got all these epithelial macrophages kind of walling this off, doing their best to phagocytize it and clean it all up. And the stuff inside is really interesting. I'm not sure what its exact composition is, but I would love to know. My guess is some of it is probably a mix of like necrotic debris, but it's got this interesting brownish stain, and we've got all these interesting refractile fragments in here, probably off the metallic foreign body. I'm not sure exactly what they are, what the composition is, just they look kind of cool. And then we've got tons of macrophages around that encapsulated structure. which are probably laden with a mix of hemosiderin, so kind of chronic hemorrhage at the site, and maybe something else kind of iron rich. So that's kind of neat. Another really neat feature of this is we walk around the edges of where this pellet was sitting. We end up with these weird little like crisp ring shaped guys. They often have this like, ring and ring look like that, with a little break in the middle. There's more of them. There's even more of them. And they're kind of distributed multifocally all the way around the outside of this encapsulated focus where the metallic foreign body was sitting. And I also have no idea what these are. I think our conclusion is that they might have been something off of like the coating of the metal or something like that. If you know what these are and have seen them, please let us know because they're very cool. And I would love to know more about the composition of all of this stuff. Can also try to polarize it. Just fun. Use the fancy polarizer and turn it blue and orange, maybe. Under pink. Yeah, the camera is sort of cooperating, sort of. So yeah, these things at least are birefringent to some extent. A lot of the refractile stuff that was actually in here are not birefringent, although there's occasional birefringent things. So maybe something there, for example. Anyway. So a lot of this is just going, ooh, that's neat, and I don't exactly know what it's made of, but just interesting. We don't see BB pellets all the time. I will also note that they describe, I don't know if I mentioned it before. I think I did. Hang on a second. Here we go. The lower eyelid mass has reportedly been present for several years without change in size or causing any irritation. And on thoracic radiographs, they did also find metallic sub-Q foreign body. So there are others around the body too. So yeah, just kind of neat. We don't get to look at the histology of sort of reactions surrounding a presumed BB or a metallic foreign body too often. And then I guess because these are eye rounds after all, here's our eye. We've got a nice cupped and atrophied optic nerve back there. See that? Here's the front. Walk up here. I'm going to become a level. Oh, that's even worse. Hang on a second. Not great. So it's kind of weird at this level. Close this gap in your mind. This is an artifactual tear in the iris. But here's the anterior iris surface. I'm following it right now. And then it kind of turns around and this iris-like tissue crosses the iridocorneal angle and contacts the end of Descemet's here. There. And in addition, at this level, there's no evidence of a ciliary cleft, no evidence of pectinate ligaments, no evidence of a trabecular meshwork. Everything's locked up tight. Long story short, this was a pretty pathognomonic case of gonial dysgenesis, so primary glaucoma in the eye, which is the actual reason why they did surgery. But the BB was cool, and I wanted to show it to you. So that's it. Okay. Put up the diagnosis. Here you go. Baby again. Here you go. And I will say somebody added kind of reminds me of carpet fabric. Oh, Kelsey Briggle added kind of reminds me of carpet fabric fibers, but seem bigger than the ones I normally see embedded in skin crusts. So that was one comment about those weird ring-shaped fibers or shenanigans around the BB. Cool. If there aren't any questions, we'll do the next one, and I'll hand the floor over to Jamie Miller. Oh, boogers. Oh, yeah. Here's the full morphologic diagnosis for the foreign body, and then I wanted to give you an actual shorter one that's easier to read. All right, okay. There you go.
All right. All right, I'm Jamie Miller. I'm going to finish up our last two cases for rounds today. So this case, that's up on the screen right now, is the left eye from a 6.5-year-old mixed breed female spayed dog. This patient presented to the ophthalmologist with a left-sided head tilt and being neurologic for weeks. The ophthalmologist diagnosed a panophthalmitis in the left eye. They did some blood work, which seemed to be normal, and a fungal panel, which was also negative, and started on medication. And at recheck, they noted a retinal detachment on ultrasound. So the owner elected to move forward with enucleation of this globe. So this is our hemisection view with our cornea at the top, lens in the middle here. We have this tissue here that is extending from the back of the globe, which is a detached retina. It's kind of plastered on the back of the lens. It's also very thick and very white. We can see some strands also coming off, connecting it to the back of the choroid here. The choroid is also pretty thick in the back here, and it gets a little bit harder to see optic nerve, but we'll take a look at all this stuff histologically. We also noted that there was some like clear sparkly fluid in the anterior chamber, as well as in this subretinal space here. So let's take a look. So starting with our subgross. All right, so here is our cornea at the top. Iris leaflets here, a lens in the middle here, mostly unremarkable. And here is that lovely detached retina, and you can see how kind of thick it is. There is definitely some increased basophilia to the retina, kind of on both sides. Got also basophilic dot here that will be useful later. If we look back at our choroid, we can see that there's also this basophilia lining the surface here. So we have an epichoroidal membrane, and then back at our optic nerve, that looks fairly good. Subgroups. All right. So starting with our cornea, again, that wasn't too bad. Getting a little bit closer here on our surface of our iris. We have a nice pre-iridal fibroblastic membrane. We've got a moderate number of like lymphocytes and plasma cells that are infiltrating the iris and ciliary body stroma. And as we keep moving backwards, here we can see a part of our detached retina and some cellularity here. And here is our choroid, and we can see this really thick membrane on top of the choroid. We're dorsally here, so here is our tapetum, and we have this lovely fibrovascular membrane. As we get closer, we can pick out some inflammatory cells, some lymphocytes, plasma cells, but we also start to see these little refractile organisms here in this membrane. Some of them have this little tiny like basophilic center as well. About 8 to 10 microns in diameter or so. I'm going to follow this around. A bit lower power. That's sick. Coming around, it starts to get a little bit more cellular back here. Here's our detached retina right here at the optic nerve head. We've got our nice lamina curvosa here. And as we come ventrally, it gets a little bit more cellular in that membrane, in the choroid here, and on top. Again, we start to get feeling, we've got these nice little, like American football shaped, pigmented pigment granules that are consistent with like RPE granules. And then we can see a myriad of these little organisms here. So if we So if we follow this around, coming into our retina, We'll go there in just a second. We can see that the retina also contains a similar infiltrate as well. There's also these multinucleated giant cells that again just contain a myriad of these organisms here. Blue dot. No, you guys are all in suspense here, wanting to know. It's really hard to see this feature, but occasionally we can see some endosporulation of this organism. So this one has 2. This one down here maybe has 3 to 4. It's a nice little wedge-shaped endosporulation to it. Maybe even this one here. Maybe this one might have that. Maybe a classic Mercedes-Benz symbol, depending on which way you tilt your head. So if we think about organisms that do endosporulation, there's a couple of fungus that can do endosporulation, notably Coccidioides immitis. Those organisms would be probably a little bit bigger than this and would have a lot more endospores in them. Rhinosporidium seabrii is another fungal agent that can do this. They usually have much larger sporangia, up to like 300 microns in diameter. And I believe in dogs, most often it's found in the nasal cavity. There's also the lovely, hopefully won't butcher this too much, the Bactrochytrium dendropiditis, chytrid fungus in frogs, also in salamanders, the B-sal in the salamanders that cause the skin disease in those creatures, which this is obviously not a frog. And then other than those fungus, we have algal organisms that also do endosporulation. Most common ones that we see are probably Prototheca as well as chlorella. Histologically, with normal staining, it's hard to tell those two apart, but chlorella does have chloroplast and is a green algal organism. So would most likely have stained the tissue green. So these features are most consistent with Prototheca in this case. And just in case you're having a difficult time seeing those organisms, wanting to get a better scope of just how many there are in here, I did a PAS for fungus stain, which has a counter stain that stains the tissues green and our organisms bright pink. And so you can see back here in this membrane just how many organisms are here. They're so pretty. So here's our chemotherapy for today. A lot of them were kind of empty shells of the sporangia, but again, some of them did have some basophilic stuff in the center. All right, so so here's our morphologic diagnoses. We had a pretty marked granulomatous endophthalmitis and some lymphoplasmacytic panuveitis and retinitis with those myriad kind of free and intrahistocytic algal organisms that were consistent or suggestive of Prototheca species. Typically in dogs, they ingest these organisms from groundwater, and ocular protothecosis is sometimes associated with systemic disease. A lot of times it can manifest as bloody diarrhea clinically with the colonic form of Prototheca, but they can also do more generalized systemic illness, including neurologic signs, which again, this patient did have a head tilt and neurologic signs for about 2 weeks.
Was that the only thing they described as neurologic thing?
Yep. And then they eventually saw a retinal detachment on a check on the ultrasound. So, yep. So a nice little case of ocular protothecosis. All right. And then my last case is from a 9-year-old female spayed domestic short hair cat. We actually got both eyes from this cat. It didn't have much detail in the history other than the owner had reported blepharospasm in the left eye for the past few days, but the patient appeared to be getting around quite well, kind of coping at home. And on examination, the ophthalmologist confirmed both eyes were glaucomatous and blind, and had pretty high IOPs. The left eye was 96 and the right eye was 72. And they had it on the necessary medications for high intraocular pressure, but they decided to go ahead and enucleate these blind eyes. So I made a note here that this is a picture of the other half of the globe because there wasn't really a whole lot to see grossly, but after seeing the histologic appearance of this case, I wanted to make sure we had a picture to show. So again, cornea is at the top. Here's our iris here. The lens, maybe a little bit cloudy. It's a very small piece of it because again, it's the other half. So most of the lens is in the sections that are on the slide. And then pretty much not a whole lot going on there. And the findings in this case were very similar in both eyes. And so this one that I'm going to start with, possibly only show you, is the right eye. So again, cornea at the top, we have our iris leaflets here, lens in the center, around the choroid here, and we can see that the optic nerve is very cupped here in this cat. But otherwise, not a whole lot else to say, obviously. All right. And there's not a whole lot else to say about the cornea. Looking back here at the iris and our iridocorneal angle, here we have it's a nice open angle, very nice open trabecular dorsal cleft. We've got some nice primary and secondary ligaments. Our trabecular meshwork looks pretty good here. Check out the other side. Also the same going here, very nice normal looking angle. As we head back, the lens was pretty unremarkable as well. And again, optic nerve, it's fairly cupped for a cat. It's very gliotic. And if we look a little bit closer at our retina, and here's the lovely tapetum in the cat, we can see that it maintains most of its layers very well, except that we're missing all the ganglion cells here. So this is a pretty classic appearance of chronic glaucoma in a cat.
Jim, go higher magnification there because that's such a beautiful example. See all those cells we're seeing there at where the ganglion cells should have been? They're pretty small compared to their size with the size of the cells at the inner nuclear layer. So those are not ganglion cells. Cats have displaced amacrine cells in the inner aspect of the retina. And once, in cases like that with chronic glaucoma, when all the big, obvious kite-like ganglion cells are gone, if you're not careful, you might interpret those as ganglion cells. You know, they say the hardest thing in pathology to see is what's not there, right? So since there's almost no ganglion cells to compare with, it seems like they, oh yeah, I mean, they're there, but these are not ganglion cells.
Awesome. All right, so definitely have evidence of glaucoma. So we are gonna head back. Excellent. To our iridocorneal angle, just to double check it again. There's no fibrovascular membrane, no posterior synechia. All of the structures of it look pretty good. But if we travel into the limbus here, into our sclerovenous plexus, we can see that the veins here are surrounded by small to moderate amounts of this myxomatous paucicellular matrix. So this is pretty classic for feline primary open angle glaucoma, where all the structures in the angle are pretty much normal looking, and what the lesion is this myxomatous matrix that surrounds the sclerovenous plexus here. And so the word primary in sort of the diagnosis can be a little bit confusing, because often primary, you would think that there would be structural change or abnormalities in the iridocorneal angle that are leading to the decrease in the aqueous outflow and increase in intraocular pressure, and then thus glaucoma. But really what this is kind of more of a post-trabecular obstruction caused by this material. We don't really know the pathophysiology in this disease, but again, seems to be mostly more likely a post-trabecular problem rather than something that's like a primary structural condition in these cats.
Yeah, if you look at those cells, I have, unfortunately, I have a particular interest in these cases. I say unfortunately because they're really hard to study. They're rare, and they're hard to recognize clinically, on the early stages. But mostly you can see that the lumen of the vessels are still open, which is a question people ask. Well, but the lumens are there. I've measured the lumens of these guys compared to other normal and other affected glaucomatous cats. Didn't have that. The lumens, they seem to be narrower in general, but they're not collapsed. But I have to remember that the aqueous drainage from the eye requires a gradient of pressure to happen. So the pressure in the anterior chamber, it's bigger than in the angle structures, that's bigger in the vessels, that's, so that differential allows aqueous to flow continuously. If you change a little bit of the pressure, you don't need to have like a complete obstruction, but if the pressure in that region around the episcleral vessels increases, it might cause a physiologic stoppage of the aqueous drainage, because then the pressure in the vessels goes up and sort of equates the pressure in the anterior chamber. So there's a stagnation of the aqueous drainage. Oh, that's a beautiful section there, Jen.
Yeah, so this is the other eye. This is the left eye. So again, our myxomatous stuff kind of around the sclerovenous plexus.
So looking at there,
Oh yes.
you can see where if the intrasclerovenous plexus connects with the vortex veins, and where these vessels will connect with the systemic vascular channels over there. I've always wanted to take a look at that area because it looks like a bottleneck area where things could be, but it's really hard to get a section through that.
Serendipitous there. And then again, the other eye, evidence of chronic glaucoma as well. So just a lovely example of open angle glaucoma in a cat. This is usually affects adult animals, and in our collection, about 60% of the cases that receive present with bilateral disease, which was what happened in this cat. And we've got an average time for glaucoma to develop in the second eye after the first diagnosis is made as about 400 days, give or take. So usually something that affects both eyes in older cats. So pretty cool. There are no other questions, comments about this case. That wraps up rounds for us. So thanks for coming, everybody, and we'll see you guys in 2 weeks. Thank you.